Faced with the rising cost of healthcare, limited resources, and too many uninsured citizens, Arkansas's healthcare system was at a tipping point. As we considered options to expand access to more Arkansans, we knew that in order to transform the state's healthcare system in a sustainable way, it had to be redesigned, with efforts to improve quality and control, if not reduce the cost. The Arkansas Payment Improvement Initiative is the result of stakeholders across the state working together to develop a new system to better serve all Arkansans.
As doctors, healthcare professionals, and community leaders, our number one priority is, and always should be, the people we serve. As patients, we want timely, high-quality care delivered by a trusted doctor or team. As employers, we desire a healthy and productive workforce. While our country's healthcare system has the best medical and technological capabilities in the world, healthcare is weakened by an inefficient delivery system that doesn't always provide the best and most efficient care that people need. For example, 50% of adults report problems with their care coordination, notification of test results, and communication among their doctors. And 1 out of 3 hospitalized patients are subject to mistakes that have the potential to harm rather than help them. And mistakes are costing money. Recent studies have shown that a third of healthcare spending, an estimated $750 billion, pays for things that don't even improve health. Other large industries, such as the aviation industry, learn quickly from their past performance and adjust accordingly. They can't afford not to. So why can't one of the most important, if not the most important industries in our country do the same?
Even before the Affordable Care Act was put into law, Arkansas led the nation in beginning a comprehensive transformation of our healthcare system, one that improves quality and controls costs by putting healthcare providers back in charge and rewarding superior patient results. And for the first time, this innovative plan aligns the way healthcare is paid for with the expectations people have for high quality and efficient care.
Introducing the Arkansas Payment Improvement Initiative, or APII, a multi-payer initiative with participation from public and private insurers. Unlike any other state in the nation, Arkansas has successfully pulled together public and private insurers, healthcare providers, policymakers, patients, and others to craft and launch an initiative that revolutionizes the way healthcare is delivered and paid for. With all parts working hand in hand, Arkansas is improving quality, eliminating waste, and bending the cost curve. The result? A healthcare system with long-term sustainability. Arkansas's initiative is designed to make the best use of our healthcare resources by paying healthcare providers for coordinated care and patient results, rather than just individual treatments and services. Public and private payers, along with providers, have taken on total system transformation, which includes patient-centered medical homes, health homes, and accountability for episodes of care. Arkansas is well on its way towards a value-based payment system for healthcare.
Primary care has been under-resourced for a long time. And in fact, it's really been struggling and they're not getting new entrants. It's really been a real shame and a missed opportunity for the nation. Our program gives some upfront investment on a per member per month basis, risk adjusted, so people can make the investment to change their practice from high volume, acute care orientation to one where you're doing preventive services, chronic disease management, outreach, identifying high-risk patients that need greater attention between visits, really begin to allow people to restructure their practices with this upfront investment to do what they were trained to do, but the current system and reimbursement doesn't let them do.
The new system helps ensure patients don't miss important opportunities to prevent illness and stay healthy. When patients do need treatment, the system will be easier to navigate and they'll get high-quality results.
I participated in some of the work groups, and one of the work groups we sat around and we talked about how the patient care is provided for congestive heart failure patients. The input I was able to provide was to tell them about a story of when I first went into congestive heart failure, how I ended up in the hospital. I gave a comparison of how my care was different from the care that my mother received. My mother was also a congestive heart failure patient. My mom was in Southeast Arkansas, and her care was totally different from the care that I received. Eventually, my mom died November 6, 2007 from complications of congestive heart failure and other illnesses. One of us survived and one of us didn't.
After 18 months of input from experts across the state, research, analysis, and development, Arkansas's initiative is now being rolled out in every community throughout the state.
The Arkansas Payment Improvement Initiative started out as an idea that physicians in particular were not too fond of. They talked about bundled payments and partnerships, and we really didn't know what that was. As it's progressed and as it's been developed, physicians have really stepped up to the table. They've been on work groups, they've even got an advisory council that they've put together. And so I don't think we'd be where we are today with the Payment Improvement Initiative if not for the physicians stepping forward.
The first and core component of Arkansas's new system is the patient-centered medical home. Medical homes are not physical locations, but a working partnership between a patient, their family, and their primary care team. Well-coordinated care designed to keep patients healthy reduces unnecessary expense, leading to a more affordable healthcare system. Each team is led by a designated primary care provider and includes nurses, care coordinators, and other support staff who actively communicate with each other and with any specialists, hospitals, pharmacies, or community supports that a patient may need. Think of it like a football team. The leader of the team, the quarterback, calls the plays. In the patient-centered medical home, the quarterback is the designated primary care provider who is accountable for managing a patient's overall care and makes decisions that impact quality and cost. In the past, our health system generally did not support a leadership or quarterback role for primary care providers, making it difficult to coordinate care with other providers in order to keep the team from fumbling the ball. This has led to a fragmented and uncoordinated system where things like duplicate tests occur. Not only is this inconvenient and sometimes even harmful for patients, it's a big reason why the cost of health care has continued to rise.
As we reflect over the last few years and some of the changes that are being put into place, I'm very positive about the fact that Arkansas physicians have been able to be involved in the process as it's moved forward. I'm very pleased that we are now putting an increased value on primary care, and I think that as we continue to move in this direction, I think we are likely to increase the quality of care that all Arkansans receive. I think that the overall health is going to improve.
Developing successful medical homes that support a quarterback and his or her team requires improving the traditional fee-for-service payment system. Fee-for-service is based on providing sick care, paying doctors for office visits, and for each individual procedure. Earnings are based on quantity of patients and procedures with no financial incentive for quality and cost control. In effect, sick patients are more fiscally valuable than healthy ones, a situation most physicians find frustrating and basically unfulfilling. Arkansas's medical home model is aimed at improving the quality of care patients receive and controlling costs by keeping patients healthy. Preventive screenings, vaccines, and early proactive treatment of diseases like diabetes and high blood pressure not only make for a better quality of life for the patient, they help avoid much more expensive healthcare needs down the road.
Because of coordinated care, because now I can ask my doctor questions and he actually provides that education for me, I'm not at risk so much as going back to the emergency room or ending up in the hospital with congestive heart failure.
To create a medical home-based system, providers are now financially supported with upfront payments to help coordinate care and make improvements to their practices that will lead to more touchdowns for their patients' health. These improvements include implementing a support team to ensure patients get the care they need in a timely way without missing opportunities to keep patients healthy. And they include installing tools for easy access to electronic patient records so the quarterback and team can make and then execute the best calls for patient care. In order to continue to receive these practice support payments, providers must meet certain practice transformation milestones, such as identifying high-priority patients, providing 24/7 access to care, same-day appointments, and integrating the use of electronic health records. Doctors must also meet certain quality targets aimed at improving care and reducing unnecessary costs. These targets include making sure high-priority patients have a care plan in their medical record and that they see their primary care provider at least twice a year. Also included is increasing follow-up care after patients have a hospital stay to avoid all too frequent unnecessary rehospitalizations and decreasing use of the emergency room for non-emergency care.
We've already seen in some of the things that we've implemented that we've seen a benefit. We've started following up with all of our kids whenever we see that they've been to the emergency room. We now get reports from the hospital, so when they go to the emergency room, we follow up on it. And the parents really appreciate the fact that we follow up on that. We're getting them in for treatment that's necessary and hopefully preventing future emergency room visits.
By avoiding unnecessary costs, providers may earn additional bonus payments called shared savings, which further support a shift from sick care to better health care.
To be eligible for shared saving payments, shared by the insurance carrier, providers must meet additional quality targets. These include making sure patients get the right preventive screenings, tests, medications, and follow-ups. These targets are meant to catch problems early and reduce major complications or illnesses. This is good for patients, for the bottom line of healthcare spending, and creates an opportunity for increased earnings attached to the appropriate level of decision-making within the healthcare system, which could substantially increase take-home pay for primary care providers. Primary care transformation is making Arkansas a more attractive place to practice medicine and may influence more medical students to work in primary care in Arkansas. Over time, most Arkansans will have a medical home that offers local access to preventive care and assists patients in proactively managing their health.
The second component of this new system is for patients that will need additional services and support that go beyond medical care, something called health homes. Health homes are for those with special needs, such as the frail elderly, the developmentally disabled, or those suffering from severe or persistent mental illnesses. Health homes identify and provide coordination of additional services to provide for underlying social needs like transportation to appointments, condition-specific educational programs, and help in overcoming physical limitations for people facing complex health challenges. Both medical homes and health homes will expand access for patients through extended office hours, or in some cases, use of technology improvements like video calls and other electronic communication.
The third component of Arkansas's Payment Improvement Initiative is an episodes of care model. With so much variation in the cost of performing common procedures and treatments, episodes of care offer the best opportunity for reinforcing best practices, resulting in improved quality and significant cost containment. This is designed to improve health outcomes and reduce inefficiencies when a patient needs a certain treatment for a condition, such as pregnancy, congestive heart failure, joint replacements, and other procedures or illnesses that require several resources that account for a large chunk of healthcare costs.
We all know that there's a lot of variation in the way physicians practice medicine. It's not necessarily good or bad, there's just a lot of variation. If narrowing that variation can help us reduce healthcare costs, and as we say, bend the cost curve over time, then I think everybody benefits.
Unlike other industries where more expensive products are typically higher quality, expensive healthcare services often don't mean better outcomes for patients.
Today in America, we pay too much for things that we shouldn't pay for in healthcare. There's too much waste in the system. And the model that Arkansas has developed, which is paying for valuable, effective, quality services that incents the providers to organize differently, will actually be transformative and be a lesson for the rest of the United States on how to change the healthcare system. We have providers that are primarily being paid on fee-for-service, on volume. And we're moving to a system where providers will be paid based on their quality. So by aligning and all payers paying from the same methodology, we will make it easier for the providers to understand what their objectives are that we want to achieve, which is higher quality and lower cost.
To help maintain high quality and establish acceptable cost levels, medical professionals and industry experts use real historical costs and evidence-based standards for appropriate care to determine an achievable cost range, called thresholds, for all of the care a patient receives within a certain period of time for each episode. For example, the pregnancy episode includes all treatments and prenatal visits, labor and delivery, and 2 months of follow-up care. For each episode of care, a principal accountable provider is designated as the quarterback for that episode. This provider is the main decision maker for most of the care provided during that episode and is in a position to coordinate that episode with other providers who may also see the patient during that time. Quarterly reports relative to each episode show how their performance compared to that of their peers as well as establish quality standards. These reports help providers identify areas where they could make improvements.
This initiative would have never gotten anywhere without the capacity to crunch a lot of data. And so in order to make this work, we had to give providers a sense of where they've been and where they could go. And we're giving, in the episodes in medical homes, information that they've never seen before. Not only are they seeing what their practice is doing, they're seeing what their patients have had during the journey. So they're seeing what other providers have done in terms of spending resources to get outcomes while they've taken care of the patient. We're showing the doctors and the hospitals data that happens outside of their system so they can get a sense of what they might have to go and tackle. This is really something new. We're able to show them that compared to their peers, their patients are using more radiology, more ER, more pharmaceuticals. It gives people a chance to react to where they've been so that they can be potential winners in the future.
Providers share in the savings or excess cost of an episode, depending on their performance during each episode. Here's the breakdown. To use one type of episode of care as an example, let's say a patient goes in for a total knee replacement. As usual, the patient gives their insurance information and the facility then files the insurance claim. Then, information about quality and cost of care for that knee replacement is summarized and transferred into a provider portal that can be accessed online. Here, providers can view reports that show the overall quality of the treatment and the average cost for all of the hip replacements they perform. The provider reports also include information for all of the other types of episodes for which they are accountable.
Let's say this provider's average cost for a knee replacement is $18,000 for all associated charges, including hospital, physician services, the cost of the replacement knee, lab fees, etc. For each type of episode, historical costs in Arkansas and standard best practices have been analyzed. Appropriate and realistic cost thresholds for each type of episode have been agreed on and set, ranging from acceptable to commendable. The provider's average cost of $18,000 for a knee replacement is compared to the set thresholds. If a provider's average cost is above the acceptable level, the health provider will pay back a portion of the excess cost. If the final cost is below the acceptable level, or commendable, and the provider has met or exceeded quality standards for the episode, he or she is rewarded with a portion of those savings. This system provides a significant incentive for medical professionals to manage the quality of care their patients receive and to monitor costs that they may otherwise not have paid attention to. Let's do the math. At the end of the year, the provider has performed 10 knee replacements at an average cost of $18,000 and has met quality standards. If the commendable cost threshold was set at $19,000, then the provider would have saved $1,000 on average for 10 episodes, or $10,000 total. This provider may then be reimbursed with up to 50% of these savings, or $5,000 for that period.
So we've designed this program where 80% of providers, hospitals and doctors, are either going to be winners or revenue neutral. The better clinical doctors bought into this immediately, realizing that they could be winners in this program, that they could take higher risk patients, get better outcomes, and for a change, get paid more.
The patient-centered medical home and episodes of care have aligned the incentives so that the provider has the best model for the right care, the right amount of care, and the best care for the patient. And this can be a model for other states and other payers within the United States.
The Arkansas Payment Improvement Initiative is an example of transformative change accomplished with all stakeholders working together toward a common goal. Being led by the Arkansas Department of Human Services Medicaid program, there is a lot of power behind Arkansas's health system transformation.
In Arkansas, we have done an incredible job of bringing multiple payers together. We are actually known across the country for how well the payers get along in our state. I've been with Arkansas Blue Cross and Blue Shield for 25 years and never imagined that I would actually have Medicare, Medicaid, Qual Choice, as well as Humana together every Monday, aligning quality measures and support for the practices here in Arkansas.
And there's significant ongoing input from technical development work groups, providers, patients, and other stakeholders.
We think this is a unique opportunity for the providers to own the changes that have to happen in healthcare to be sustainable. We've often said that patients, providers, and payers, all three, have to be transformed, have to be invested in healthcare reform in order to have a sustainable healthcare system.
As more and more citizens gain health coverage, Arkansas is moving forward with a sustainable healthcare system that will truly meet the needs of the entire population, while rewarding providers for delivering high-quality, efficient care and making Arkansas a better place in which to live, work, and practice medicine.
Our healthcare system is transforming because of the Arkansas Payment Improvement Initiative. Both individuals, providers, our healthcare system are starting to see the positive effects of improved quality, more streamlined service, and cost containment. This is a permanent change to our healthcare system, not a demonstration project or a pilot project, and employers across the state are recognizing the value. Some of our largest self-insured companies have joined and are starting to pull in the same direction as our commercial carriers and our Medicaid program and the federal Medicare program. By pulling all in the same direction, we reinforce and support providers to improve quality, streamline our care, and get better outcomes. If you're responsible for paying for healthcare services in the state, we hope you'll consider joining the Arkansas Payment Improvement Initiative. We're increasingly on the radar screen on the national stage as a model that's being successful in a state with big challenges. As we move forward, this is an important change. Our families will have better care, our communities will be healthier places to live, and our employers will have a healthier and more productive workforce.